All right, so the foot and ankle are very complicated, and the number of bones here and the number of ligaments is simply staggering. Obviously, we're not going to, you know, provide a master's class on this due to the complexity of it, but let's kind of focus on the big picture here, which is what are the areas, what part of the anatomy do we need to understand to really get a sense of where people have pain here?
Sure. Well, it depends obviously on the population we're talking about. So if we just talk about athletes for a second, people who are very active and, for example, run a lot, we're interested in a number of things. Let's focus on the top picture here. This is the heel bone, and this is where the Achilles tendon attaches to the bone. And we do see a lot of Achilles tendonitis, and that's a very difficult problem because there are not a lot of great treatment options. Surgery doesn't do great with tendinopathy of the Achilles tendon, and only when it's ruptured is there sort of more of a plan on how to address it. Interestingly, I don't think there's an increased incidence of tendon ruptures in the setting of tendinopathy. We don't really see
Interesting.
that.
So tendinopathy would just present as pain
Mhm.
there, but that doesn't necessarily increase the risk of rupture.
My reading of the literature up to date, and I don't do a lot of foot and ankle surgery, that's been my understanding. And I've treated lots of people over the years with Achilles tendonitis, and I don't remember ever a case where they came back, oh, I look at that, I ruptured it.
Interesting. While we're on the topic of rupture, how much of a concern are fluoroquinolones? Everybody asks me this
Mm,
question. I don't really know the answer. So,
right.
ciprofloxacin, drugs, levoquin, these antibiotics. I know
Yeah.
that, we're told that they slightly increase the risk of a subsequent rupture. How big is that increase in risk,
Yeah.
and for how long does it preside after the antibiotic?
I don't know the length of how long it presides, but I do know that, and mine is sort of a sampling error because I see
You
it.
see the
I
cases.
see it more than you do. So because that's who's coming in, and uh, I've seen it after one dose. So I don't know how to
How
guide
long
people.
after a dose? Someone has a dose and then they.
Within a week or two, I've seen it. So, and it usually, so this is what I tell people, it's not a reason not to take the medication, but if you start to feel anything, you have to stop and rest, because I feel like that is one of those
Are
situations
there
where
warning signs to an Achilles rupture?
they start to develop pain, and that's when I stop. But I
But
don't,
we just, but it's not tendinopathy.
it's some,
So what's the pain?
I don't know what the mechanism is for it that would, there is some sort of tendon inflammation that's happening, but I'm not sure.
Okay, that's a little disconcerting.
Yeah.
So what are we doing to prevent this? Because this is definitely the middle-aged person injury, right?
The
The
tendinopathy.
well, or just the rupture altogether.
Right.
It's the I'm gonna go run
Right.
around with my kids, and lo and
Right.
behold,
Right.
I hear the loudest bang, and your calf balls up, and you're next thing you know, you're in a boot for God knows how many
I
weeks.
think maintaining muscle strength, calf flexibility, making sure your gastrocs and your soleus have good flexibility, both of those separately. I think that overtraining can be an issue in this circumstance. So just to proceed with care. You can't necessarily do everything you wanted to do when you're 20 and 30, because that tendon degeneration is a biologic event that affects all of us. And again, if you're staying healthy throughout your lifetime, it may or may not help you, but it's certainly possible that
I
maintaining.
feel like such an
Yeah.
important part of this is jumping.
Yeah.
So, literally just, jumping rope, doing the
Right.
types of activities. Like my warm up always sort of consists
Yeah.
of I have a particular jumping routine I always do, and it's not super taxing. It's
Right.
not I'm not jumping, onto 36-inch blocks or,
Right.
doing plyometric explosive stuff.
Right.
I do it sometimes, but on a daily basis, I'm trying to make sure I'm putting some bounce
Yeah.
in there. My belief is that that's a valuable way to maintain elasticity in that part of the
I
body.
would agree, and I think it's also it's a neuromuscular training. The neural part is just as important, because I think that's really what happens, is that it's always vulnerable when the
Yep.
tendon degenerates,
Yep.
but there's a mismatch between the firing of the calf musculature and what you're actually doing at that moment. And so having more motor neurons and well-developed motor neurons may help prevent that. And just like it prevent ACL injuries, I think it's the same thing. I there's no way that that's not helpful for all of lower extremity injuries, is to be able to know where you are in space and to have good training in those dynamic situations, because that's when people are injured. Nobody wanted to trip on the sidewalk, but what happens when you trip? Are you able to recover quickly, or do you end up with an injury?
Okay, so let's go over some of the bony structures
Hmm.
here. Maybe it's easier to look at that model, huh?
Sure. So this is the ankle joint proper, which is this is the leg bone or the tibia. It joins here with the talus um, on and also along with the fibula. So these three bones make up the ankle joint, and the surface is coated in cartilage, just like all the other joints we talked about. The talus then articulates with the navicular bone here, and then there are cuneiforms, a cuboid bone on the outside, the metatarsals, the phalanges. If we turn it to the side, this is the inner side of the ankle. This is the medial malleolus, and along this area is where the tendons that help to maintain your arch rest. So if we were to look at the tendons of the ankle, this on the bottom image is the medial aspect of the ankle, and this is the posterior tibialis tendon, which is incredibly important for maintaining your arch. And then we also have the flexor hallucis longus here, which goes to the first toe, and these are the flexors for the digits as well. If we look at the ligaments on the medial aspect of the ankle, we see here, this is the medial malleolus. This broad ligament is the deltoid ligament, and then we have this spring ligament here. And this is the plantar fascia as well, which helps to maintain your arch. And these are important structures to examine to make sure that the plantar fascia, which helps to maintain the arch, is competent, and that the posterior tibialis tendon is also working. So it's important to go through walking on your toes, walk on your heels, see how the gait progression is managed.
Yeah, and all of these things will show in the exam, of
Yeah.
course.
On the outside of the ankle, or the lateral part of the ankle, which this is where the fibula is, this is where most ankle sprains happen. So this is the main ligament that's injured. It's called the ATFL, or anterior talofibular ligament. And then we have the calcaneofibular ligament, posterior talofibular ligament, which is not as often sprained. And then we have this ligament up here, which connects the fibula to the tibia. And when people have high ankle sprains, this is often the ligament that's injured. Whenever someone has an ankle sprain, it's conservative treatment, and most people get better, but not everybody.
And is a sprain what degree of tear to that ligament?
It could be any degree. If you have a sprain, that is, if your ankle twists and you have swelling, you've torn the ligament. The question is it a complete rupture of the ligament? And so we arbitrarily say this is a grade 1, grade 2, high ankle. They're all tearing of the ligament. The degree to which they're torn or which they heal will dictate the next step. So no, it's very rare to have a severe ankle sprain without any dislocation of a joint that would require surgery, except for some syndesmosis injuries up higher. Those often will require surgery. But for the run-of-the-mill twisted my ankle playing basketball, the treatment is conservative, strengthen the peroneal muscles, but the doesn't necessarily mean everybody's going to recover, because sometimes what happens is the cartilage gets injured. And just like we talked about in the shoulder and the knee and the hip, any mechanical trauma to the joint puts you at increased risk for arthritis of that joint.
And which cartilage in particular, if you took the most common
Right,
sprain,
right.
which would be the the one
ATFL.
ATFL, yeah,
So the anterior talofibular ligament connects the fibula to the
the
talus.
talus. Yep,
And when that rotates this way, this does not rotate at
yeah.
all, you will cause injury to the cartilage because it abuts in this area,
Uh-huh. Yep, makes sense.
right? So you will see what we call osteochondral
And if you did
bone.
an MRI, would you see bone edema there in
Yes,
that patient?
yes,
Mhm.
yes. And so if someone is not recovering after an ankle sprain, I get an MRI because I want to see what the cartilage looks like, to see if they've injured the bone, if they've injured their cartilage, and if anything else needs to be done.
And if there's a small fracture there, is it still conservative? Put them in a boot?
Um, Fracture here or fracture here. If there's a crack in
If
the
there's a
cartilage,
crack there.
depends if that piece is what we call stable or unstable. So you can have a crack in the cartilage and bone unit that is in place in situ, and you could leave that alone, maybe give a boot. If that piece is detached, then that's a different
It's
ballgame.
unstable.
That's
And
unstable.
what about if you have a distal fibula fracture because the sprain is so bad that when their
Right.
foot went out, it actually broke the bone?
Right. So usually if it's
Does that ever
just
happen? The talus will break that tip of the.
sometimes if the forefoot is externally rotated, this will hit the fibula,
Yep.
and the fibula will break.
Yep.
And that doesn't necessarily need surgery. That can often heal without surgery. But if you've also at the same time torn the inner ligaments, the deltoid ligaments, you now have instability on both sides of the ankle, and then you go in and you fix the fibula and sometimes even the deltoid.
So I'm guessing that the sprained ankle is hands down the most common injury to this part of the body.
Yes.
And obviously, to your point, I mean, I can't imagine there are too many people listening to this who have never experienced a sprained ankle. They don't require surgery. What is the bread and butter of the foot and ankle surgeon? What is the type of surgery that is most commonly being done for either, well, let's not, yeah, I guess acute or
Yeah.
chronic injury?
There are different types of practices. I mean, there's a lot of degenerative problems where you have arthritis of the ankle, and I'm not a foot and ankle surgeon, but there are, once the foot collapses, the arch collapses, and the posterior tibialis tendon is attrition to that. That's a very painful condition, and you often have to fuse the small bones of the joint in order to better create a stable platform to
Which
land.
bones are you fusing?
So occasionally it's the midfoot, occasionally it's a subtalar joint, and then you can have an arthrodesis even of the ankle itself. It's called a triple arthrodesis. And
that occurs when the person's arch is so weak that they lose their arch.
there's stages. So there's early stage where you can treat it in a boot. Sometimes we just go in and address the tendon itself. More advanced stages, you start to see changes in the ankle joint. So you would never do.
How is this occurring? I mean, why isn't this a problem that is fixed with foot exercises and PT and like why would we let a person get to the point where their arch completely collapses and the musculature becomes so compromised?
Because some people have anatomy of their foot, they're pronated, flat feet, that is not easily correctable, even with exercise. It's just mechanically different. And that tendon itself, once it becomes
so stretched. And these aren't people who would benefit. I mean, I'm not a huge fan of orthotic arches, but wouldn't these people benefit from that?
Yes, and they are prescribed that. But it doesn't mean the disease process won't progress. A lot of this is mechanical. We've talked about that.
Yeah.
And a lot of this is biologic too. And so we have decent ways of helping people if they don't have a biologic problem. We have decent ways of helping people with mechanical problems. But it's all of these factors play into whether someone would benefit from exercise, right? But so there are things that can be done nonetheless. So you can give people rigid shoes to help with their feet and allow them to exercise other parts, right? So just because one area is deficient, you can fuse the ankle so the pain goes away and still get on a plan to maintain the health of the rest of you. But if your foot kills with everything you do, you can't help any of the rest of it.
So when people talk about an ankle fusion, normally they're talking about tibia to talus.
Yes.
That's the normal fusion.
Right. Now, that was traditionally what's used. Now, again, this is not my field, but there's also ankle replacements now too, which are becoming more popular because, again, the technology is improved, but that's not the same patient necessarily.
What are the other injuries to the ankle and foot that require surgical intervention?
So there are fractures of the fifth metatarsal. So this is the fifth metatarsal. And you can have fractures of the proximal fifth metatarsal where there's a tendon attached here called the peroneus tendon, which pulls off that piece, and that rarely requires surgery, and that tends to heal. If you fracture it right here, less than a centimeter higher up, that fracture is in an area where the blood supply is pretty deficient. We call it a watershed zone, and that often won't heal. So sometimes we'll make those people, so you break it here, oh, don't worry about it. You can wear whatever shoes you like as long as it doesn't hurt. You break it here, oh, you need to be in a cast or a boot for 6 weeks. Now, weight bearing or surgery to put a screw in there.
Wow.
Right. So there are certain types based on the blood supply to the bone. Certainly, navicular stress fractures are another one of those fractures that are
Is that
serious.
typically in a runner?
Yes, correct, correct.
What about the other metatarsals?
You have stress fractures tend to heal. We see it commonly second and third metatarsal stress
Do
fractures.
they have watershed zones as well?
No, they heal.
It's just the fifth
Yeah,
one.
but a lot of people have. I worry about the stress fractures because oftentimes you'll see somebody, they have foot pain, they're a runner, and then you find out they had 3 other stress fractures, right? So this is their third stress fracture.
Yeah.
At the first visit, you have to have a conversation about relative energy deficiency, right? Why are you not healing? We need you to see an endocrinologist, vitamin D, find out.
Yeah, you see this a lot in, I've seen this, at least anecdotally, so much in female runners who are basically being put into eating disorders by, running coaches.
Right, right.
So yeah, they're way undernourished.
Right. We
putting
call it the female triad, and it's a risk of osteoporosis, stress fractures, and menstrual abnormalities.
Okay, so what about a bunion surgery? I guess show us what the bunion actually is and what the anatomy is that leads to the procedure and what it is.
Sure. Well, some people develop an abnormality of the first ray where the metatarsal and the metatarsal phalangeal joint, this will start to deviate where this portion, which we call the bunion, starts to be prominent on the inner aspect of the foot. At the same time, that can sometimes affect and crowd out the second toe, and you'll get something called a hammer toe of that second digit. And so if it gets severe enough, as long as you're comfortable in your shoes and it's not painful, it's not necessarily something to do about. But if it starts to crowd out the toe and you start to develop pain, now we have to talk about correction. And osteotomies or cuts in the bone will be made to straighten out that area. And oftentimes you need to correct the hammer toes of the other digits if they're also affected.
And how do you correct those? Does moving the great toe over do it sufficiently, or do you have to?
You often, because after a while, what happens is the tendon length changes, and so you often have to cut the bone and just pin it to a shorter stump so that it's no longer painful.
And when you replace or repair the great toe, there's a screw that runs along the metatarsal.
There's different ways to do it. Some people use plates, some people use screws.
I see. And that can be quite a recovery.
Yeah, that's hard. That's just why we don't recommend it unless you're starting to have pain.
I mean, how much of that is driven by wearing super tight shoes, you hear, oh, I wore dress shoes my whole life. And how much of it is that? How much of it is anatomic variation?
It's a combination. I think it's a factor where some people are predisposed to develop it, but there's certainly a lot of cultures where tight shoes, you're going to have a higher incidence of this problem.
Got it. Anything else on the foot and ankle you want to focus on? What about the calcaneus? How often do we see injuries to that?
Well, we see stress fractures of the calcaneus as well. Also, plantar fasciitis is very common. So it's important to recognize that this area of the foot, heel pain is its own animal. Yeah. And sometimes it's attrition of the fascia or the ligament, the plantar fascia that attaches on the inner plantar surface of the bone. You could have stress fractures in this area. You can have insertional tendonitis where the Achilles attaches to. And sometimes you can have heel pain because a nerve is compressed, much like you have carpal tunnel syndrome. You could have tarsal tunnel syndrome. And sometimes people get just heel pain because they have a disc herniation that's affecting S1 nerve root, only presenting as heel pain. So it's one of those things where you sort of have to really take a close step-by-step approach to diagnosing that problem.
So taking a step back from all of this, if someone watching this is sort of in the process of interacting with the medical community, specifically the orthopedic community, how can they pick a good surgeon? What are some of the tells that you're speaking with a good orthopedic surgeon versus someone who's a hack?
It's a good question. I think you use the same judgment you have when you speak with anybody. Are they sitting down when they walk in the room? Are they sitting down? Are they looking at you in the eye? Are they talking to you? Do you feel like you're being rushed? I think that's a big sign. If you feel like you're being rushed, you probably are being rushed. And so just the ability to listen, to have someone that is listening to you. I hear a lot of people come, and I've seen people all the time who they had surgery with someone and they're seeing me about 3 months after their surgery. And they say to me, I said, well, you really should ask that question of your surgeon, because they know what they did for you. And if they're still in pain, for example. And they say to me, oh, yeah, but he's just a surgeon. He just does the surgery. I said, well,
What do you think I
I,
am?
I'm also just a surgeon. You can ask them these questions. You're entitled to have a conversation with somebody. So I think that's a good. You're not going to know till you meet them, and some people mesh well with people, other people don't. And
What are some questions that they can ask specifically to get a better sense of, um, a person's competence,
right,
basically?
it's a good question. I think if you just have to, it's a good question. I think just again the rapport you're having with the person. Let's say, for example, they say, I think you need surgery. Just a simple question: are there alternatives? Or what are the alternatives? Or why do you think I need surgery now and I can't do are there any non-operative approaches to it? And just the answer, right off the bat, you could get a good sense if they're defensive in their response. That may not be someone who's right for you. Even if they're right and you do need surgery, doesn't mean you're not allowed to ask the question about alternatives. If someone comes in with a ruptured patellar tendon and I'd say to them, you need surgery, even though that visit could be 4 seconds, I could say, oh, you ruptured your patellar tendon. I'm scheduling you for surgery next week. I'll see you then. I'll be right in my assessment of what needs to be done, but that doesn't make me a good doctor or a good surgeon. You need to explain why that's the case, what to expect afterwards. So everybody deserves a conversation about these things.
Yeah, when I talk to people about this in general, with especially with surgical procedures, I feel like when a surgeon can't give you a clear breakdown of what the complications are
Hmm.
and what the probabilities are of those complications, especially in their hands.
Right.
It's one thing to quote the literature, but I want to know, what is your risk of wound infection
Right.
here? What's the probability? How many times do your patients get wound infections?
Right.
How many times do your patients require reoperation? How many
Right.
times do your patients still find themselves in pain a year out? All of those little things. And then the other question is, what will we do if? So if I'm still in pain in 6 months,
Right.
what
What's
does your
next?
intuition tell you is
Right.
going on, and how will we work that up? And in
Right.
my experience, people surgeons who can't go through that thinking
Right.
aren't very
Right.
good at their job.
Right.
And you're playing a little bit with
Right.
fire when
It's
you
true.
go under the knife from them. You
And
might get a great outcome and
yeah.
you're fine, but if you don't, they're not going to be the ones to help you troubleshoot.
Yeah, that approach is also important. I've found even when you're not recommending surgery. For example, if I have someone come in with an ankle sprain and I say, oh, you just need to do PT, and I don't explain to them what would happen in 3 weeks, I say, follow up. I could just say, follow up with me in a month if you're not doing well. I need to go through the steps with them. Listen, here's the story. Not everybody with an ankle sprain is going to get better. You're probably going to get better because most do, but you might not. So if 4 or 6 weeks goes by, you're still having swelling pain, you don't feel like you're making improvements, I really need to see you because you may have an injury to the cartilage and we have to get an MRI. So I always give them the answer to what we are doing next if what I've just recommended isn't going to work.